So, can I ask one of the surgeons to take it up? Um, are we looking at today compartmental resection in any scenario, or is wide excision acceptable across all sites? And remember, we are talking here about limb adult soft tissue sarcomas mostly. We will have some discussion about pediatrics as well.
So coming to the first, this thing, compartmental versus wide excision in the advent of radiotherapy, the recent data all shows that the wide excision with adjuvant RT, the local recurrence rates are almost similar to compartmental resection. So in the present era, wide excision would be the accepted standard. Second would be the adequate margins of excision. So probably around 1 centimeter margin of excision is the standard, but in soft tissue sarcomas, we should all agree that it is not easy to give that 1 centimeter margin. The longitudinal margins are easy to give, but the transverse margin is more difficult. So probably the standard of care would be excision with an intact facial plane.
Can I get one of the other surgeons' takes on this, please? About what is an adequate margin, and is there something related to quality of margin? So is it simply just a number, or is it more about what tissue you're encompassing with that margin?
So in this scenario, the adequate margin of excision, you have to consider that after you excise the tissue, these muscle tissue, they tend to shrink, like up to 50% they tend to shrink. So what the data, they're saying that even if you get a margin of 2 mm, that is considered as equivalent to 1 centimeter in surgical margin, and it should be fairly good enough if we can achieve this margin in three-dimensional plane. So what he has rightly said is like longitudinal margins are easy, but our goal is always to achieve a three-dimensional margin of 1 centimeter. And regarding the quality of margin, it is like basically if you're having certain tissues, like the concept of barriers, we have like thin barrier and thick barrier. So if we are having such tissues, barrier, a margin of 2 mm is considered adequate in this scenario.
I think just to add on, sir, a certain intact facial margin is quite adequate. Sir. When we go for the 3D margin, having a proper facial margin is equivalent to 3 centimeters of margin. So that is quite adequate when you have a proper facial covering, and even if your tumor is adherent to the bone, and we have an intact periosteum, and that is still adequate as a margin.
So while reading up for the panel, remember I'm not a surgeon, so I had to read up some things. So I came across two quite interesting points, which I'm sure some of you would like to comment on. One is about to what extent should we be heroic in resecting close to critical structures, and does it make a difference? That would be at the more extreme end of things. And at the other end of things, it would be, are there any entities that you can actually get away with very, very small or even positive margins? So any of you, if you'd like to take that up from the surgical team.
The major issue was the involvement of the neurovascular structure. That is the most critical structure whenever you come across excising such tumors. But now this is not it's not an absolute contraindication. You can excise this even artery, vein, and in some cases nerves also. But you have to see what are the grade of the and what is the histology of the tumor. That plays an important factor. So if it is a low grade tumor, we can get away with having a closer margin, or sometimes positive, considering we can be adding adjuvant radiation in those cases.
Right, so came across this one, which is mid-side liposarcoma, that we can apparently get away with smaller margins. Now about the biopsy site, how do you deal with that? Because it's assuming, of course, that this is not a oops surgery, that it's a planned surgery. How do you deal with the biopsy site?
Again, for biopsy, nowadays the image-guided true-cut biopsy is a gold standard. Unless we are not able to get, we rarely go for open biopsies. So the important thing is for biopsy site resection, what the study shows that how much, if we achieve the resection of the biopsy site, how much is involved by the tumor. So if it is involved by the tumor, then the local recurrence rate is high, but it doesn't add to any survival benefit, nonetheless for biopsy site resection. But from practical point of view, whenever you undergo surgery for such cases, we usually resect the biopsy site also as well.
Unless it is an unplanned surgery,
Yeah.
a prior unplanned surgery. Most planned surgeries, if we are going for a guided biopsy, we do try to excise the biopsy site, sir.
And what about if it is one of those that turns up from the periphery having had?
Yes, sir. And sometimes we do get that kind of this, sir. And if it is, we do try to resect that, sir, because most of the times, whenever we have unplanned surgeries, the fields are contaminated. Most of the planes are contaminated. So we do try to excise that. We do try to incorporate. Obviously, what will happen is we'll end up with we'll require some soft tissue coverage or some plastic surgery, reconstructive work would be required whenever such unplanned surgeries are there. Sometimes we do get CT guided biopsies done not from the planned incision site. So probably they would have been posterior to the tumor or wherever the incision site is, far away from the incision site. At that times, we have avoided surgeries. We have avoided trying to resect them.
And can I ask again, the surgeons, do any of you use a frozen section, or what is your view on using frozen section for margins?
If it is available, yes, sir. If it is a very close margin, we do try to get a frozen section. But it is in our setup, it is not available always. So that is a slight problem.
Right. So, so we've looked at obviously doing upfront surgery, but there are going to be situations where you have unresectable disease, and the options include some form of neoadjuvant treatment, and less, I suppose, successfully if you just give medical radiotherapy. So we're going to look at neoadjuvant chemotherapy first, and where, Dr. Mohabbat, if I can ask you, where do you want to look at giving neoadjuvant chemotherapy? Would you differ in your opinion from what we put up here?
I think sarcoma is actually a discussion between the surgeon, medication, and medical observation. Actually, if it is surgeon is quite confident in operating, then there is no question of neoadjuvant. Then if it is there is especially limb sarcoma, if there is a high chance of amputation, there is actually either you can give neoadjuvant chemotherapy, but response to chemotherapy is only 10 to 20%. It's not much. You can give neoadjuvant radiation also, but still that response is around 10%. Except mixed liposarcoma, which are more radiation sensitive, they can do better when you give radiation. But there is nothing, ideally, we don't have the facility. These are giving chemotherapy with heating actually, external heating. That give a good response actually, especially in limb sarcoma or perfusion, perfusions, those things we don't have any.
And do you have any take on choice of agents?
There are a lot of trials of histology-directed chemotherapy and hypophosphamide adramycin, but hypophosphamide adramycin still is the choice. I think a little bit what trials we have, the histology-based therapy doesn't hold over the hypophosphamide adramycin or epidopsin adramycin.
Yep. So we can see on this slide that. This is a randomized trial which looked at using some customized chemotherapy based on histology versus the usual doxor and ifos. And I think we conclude that doxor and ifos should remain the standard regime. Now, obviously, the main area for neoadjuvant treatment is in pediatric sarcomas, and that's where Preetham comes in. So, can you tell us about the standard of care and about the emerging evidence?
So in pediatric limb sarcoma, as far as the soft tissue sarcomas are concerned, we predominantly see alveolar form of rhabdomyoid sarcoma, and then different grades of non-rhabdomyoid sarcoma or soft tissue sarcomas. So as far as RMS is concerned, if the surgery can be done in a non-mutilating way with a negative margin, then only upfront surgery is kind of endorsed. Otherwise, the standard of care is to administer neoadjuvant chemotherapy, which is based on alkylator, actinomycin, and vincristine. And typically, after 10 to 13 weeks of neoadjuvant, we go for local therapy. As far as NRSTS is concerned, non-abdominal sarcoma group of tumors are concerned, as I mentioned, IFOS doxo remains the standard of care for neoadjuvant for all high-grade NRSTS.
And I was just looking at this one. There is apparently some work going on with combining targeted therapy with chemo, especially in peds. What's your take on that?
So, sir, I think the same Children's Oncology Group North American study, they have shown that with the incorporation of pazopanib with the neoadjuvant chemotherapy, there have been the histologic response have been much superior when pazopanib has been added. But there was overall no survival benefit between the pazopanib versus no pazopanib arm. So as of now, there is no consensus whether to routinely include this. I think we need more data to comment more concisely on this.
So we were just referring briefly to the use of neoadjuvant chemoradiation and Shorab. You tell us when you want to look at using chemoradiation on a neoadjuvant basis. What do you think are the advantages or disadvantages of using neoadjuvant treatment?
Yeah, in the tumor board, generally we'll take up the case. And at the beginning, if it looks like that initially it is an inoperable tumor, then we will consider for neoadjuvant chemoradiation. So in this specific study, it was 3 cycles of chemotherapy followed by radiation assessment, followed by surgery, followed by 3 more cycles of chemotherapy. But what the study showed was that the grade 4 hematologic toxicity was significant. So we have to be very careful when we pick up patients for neoadjuvant chemoradiation.
But what about the radiotherapy toxicity? What has been your experience? Have you used it in patients?
In specifically in this study, the radiation dose was less than what we generally give in the pre-op setting. It was about 44 gray, which was prescribed. So generally in pre-op setting, we will give a dose of about 50 gray, followed by surgery. But what we find is that when we give pre-op radiation, the chances of wound complication is much more compared to when we give it in the post-op setting.
Right, and there is also some work on using a post-op boost, even for patients who've had pre-op chemoradiation, but quite often it doesn't really add on any benefit. The Canadian groups have studied that. So here are some of the radiotherapy issues we'll be discussing. I think we've already looked at pre versus post-op. But I mean, just for the attention of the surgeons, who obviously are the majority of the audience, why do we want to use pre-op radiotherapy? Remember, this is only commonly used in rectum and to a lesser extent in esophageal cancer. And we're talking about it here in sarcomas. And Saurabh, do you want to take us through why pre-op can actually be beneficial?
Yes, so now actually the trend is more towards pre-op radiotherapy than post-op adjuvant RT. Simply because if we go for pre-op RT, we actually know that the tumor better, because we can see it clinically, we can see it radiologically much better. Obviously, when it is post-op, we actually do not know where it was and how much margin to take. That is number one. And secondly, the vascularity. So it is very oxygenated. So in the pre-op setting, so the radiation acts better. And as I said, the chances of wound complication is slightly more with pre-op setting. But then after post-op setting also, we find complications like fibrosis and contracture, which are quite significant. So now the trend is more towards pre-op RT than post-op radiation.
And there's a very recent meta-analysis which has compared quite a small number of studies and they've looked at pre versus post-op, and there's no real difference in the local control or the survival or just in meds, but definitely there is that risk of complications. So let's ask the surgeons now. What do you worry about when you have a patient who's had radiotherapy?
So in pre-op radiotherapy, for any surgeon, the thing is, the more the time goes on, the field that we get for surgery, the amount of fibrosis it makes it quite difficult. And the second part is the wound healing component is definitely it's the chances of wound complications like seromas, skin necrosis, and those failures are higher. And infection chances also goes higher, like as per practical point of view, see the patients we operate after pre-operative distances are higher.
But whether it is esophagus or rectum, we have seen that if you operate in a particular time period, so probably we don't face all these problems. So I think the main point of discussion would be to discuss with radiation oncologist and place the surgery in the correct time period so that we don't face these problems.
Because I think for all the sites, the issue is to treat after the initial inflammation is reduced, but before the fibrosis is set in. So is there a consensus on when you would normally operate after pre-op radiotherapy? Like, is it 4 weeks, 6 weeks?
It is around, there is a 4 weeks difference between esophagus and rectum. So it is around 4 to 6 weeks, and rectum we wait up to 12 weeks also. But as in soft tissue sarcoma, we don't have a standard, so probably it is somewhere between 4 to 6 weeks is what I would prefer.
Okay, I will comment there. Right. So, coming back to some of those key radiotherapy issues, we know that we have two very good comparable options, which is post-op EBRT. I mean, we have discussed pre-op, but post-op EBRT and per-operative brachytherapy. We can use both. And there isn't any head-to-head data. We tend to take it as equally efficacious. With brachytherapy, we obviously can complete the treatment within a few sort of days, within about 2 weeks of the surgery. But obviously, not many centers have a radiation oncologist who's keen to do it, who's done it enough times, and quite often the surgical team isn't probably that confident about calling us in at that time. And we've talked about the wound healing complications. From a practical point of view, the brachytherapy is obviously a problem when it's a very large tumor. So something like 10 centimeters is not really feasible because it will end up being very close to a joint or a fold where the catheters are going to actually get messed about. Sure, what about neurovascular bungee being exposed? Do you think that is a contraindication still? Because it has been taken as a classic contraindication in the past.
Yes, I think when the neurovascular bundle is exposed, that is a contraindication for brachytherapy. And also, as you rightly mentioned, the size. If the tumor is too large, more than 8 or 10 centimeters, then obviously brachytherapy will not be able to encompass such a large tumor. So in that case, EBRT would be the treatment of choice.
So these are just a quick look at those trials. So very old trials, about 25 years old. You have a question? Yeah.
I practice brachytherapy, and I think it's the safest technique for surgery.
And easiest.
And it's the best way to save any limbs, especially growing joints. Dr. Pritham will agree, I think, for that.
And it's a very easy procedure. We have tried out intra-op insertion also, but we had found out that due to the edema and all, during the post-op reconstruction, it was a problem. So we have now prefer it, we doing it post-op implants. So the surgeons actually put the surgical some catheters or something to demarcate the region which I radiate, and that we can implant according to that. I think for sarcomas brachytherapy, there is no head-on trial because nobody practices it. But it is the better way than doing anemia. It's my opinion.
That's very well put. As I just said, not many people are doing it, so you're one of the people who are. So EDRT, we know that it improves the local control. It's a highly significant decrease in local recurrence for high grades, and even for the low grades. In both, there is no difference in the overall survival, and that's broadly the same with the brachytherapy as well. So, just to remember that these are very well established trials, and this is evidence that we're using on a day-to-day basis. But can I just set the cat among the pigeons and ask one of the surgeons, and then all the others as well, are there any situations where you would not give adjuvant treatment for a high-grade soft tissue sarcoma? We know that for low grade, if it's a small tumor, it's not really going to make a difference. But high grade, is there any situation where you would maybe skip it?
If you have achieved a good margin and the final histopathology shows that the three-dimensionally you have achieved a complete and clean margin, probably you can avoid adjuvant.
Okay.
So as far as pediatric tumors are concerned, if it was like less than 5 centimeters small tumor and you have a microscopic negative margin, you can probably give a trial of not giving any adjuvant therapy.
Just to add on, probably if it is superficial to the fascia, but otherwise we do prefer RT for most of the cases. But again, superficial to the fascia, less than 5 centimeter, very good margins, we can avoid.
Okay. I'm sure the only radiation oncologist in the audience, so you obviously.
I think in most of the cases of high-grade sarcomas, we know that the recurrence rate is high. So I would say that if it's a high-grade sarcoma, even if the margins are clear, still it is better to give adjuvant RT because the chances of recurrence is, as we know, is minimized. So I think adjuvant RT should be.
I know the medical oncologists are getting a bit bored, so can I ask you, is there a role for adjuvant chemotherapy at all?
I think there is no trial to prove that adjuvant chemotherapy is improving the OS. Actually, but if you see the high-grade tumors, larger tumors, chemosensitive sarcomas, usually the NCCN also tells you.
And what's the consensus in using these various nomograms and mispredicting tools? There's obviously a lot of them. There's something called Sarculator, which I just came across. And these mainly apply to the most common histologic types. And people for chemotherapy would be probably those with a 10-year predicted overall survival of less than 60%. So, do you normally use it in your MDTs? Or do you just go with the histology and the tumor size and grade? Because there are many different combinations used in the nomograms.
We usually go with the post-operative histological findings, and based on that we base our adjuvant treatment.
With the others?
Right now, we have not been using this, so I have to.
So, the audience, are any of you using the nomograms? It's very interesting because every so often we have these being published, but nobody seems to be using it. No. I mean, I feel guilty about it, but
Actually, other than breast, I don't think we follow any nomogram.
Sometimes prostate.
Sometimes prostate, right? But sarcomas, I don't think anybody
Anybody is doing.
One more point of contention here is that most of the nomograms have quite a number of entries which have to be made, the details which we need. So probably in peripheral centers, we don't get that much details even on pathology. So there are some logistic issues and some other pertinent problems which we face in peripheral centers. So probably depending on the subsite, as in breast it was discussed that most of us do use. But we have to see what details are needed in those mammograms and probably we'll be able to get it into the operative settings.
Second thing is the number of cases. If we see a lot of breast cases as compared. I agree that many will agree that we don't see that much of soft tissue sarcoma cases. We usually put this component of application.
So the reason why we have to be careful about obviously using any adjuvant treatment is that there are going to be problems with radiotherapy as well. Dermatitis and fibrosis, even contracture, we kind of tend to accept, but definitely not the three down below. Fractures are going to be difficult for a patient to accept. If you're going for limb salvage, they don't want to end up with a useless limb. And there is a real risk of second malignancy. So, Saurabh, do you want to say something about that?
So fracture is something which we generally do not encounter, but then we have the parameters which when we are planning we have to maintain, like the mean dose and the maximum dose should not exceed a certain value, and obviously the volume receiving 40% should not exceed a certain value. But in my practice, I have not seen because of radiation-induced fractures in post-op settings. But then we have the parameters which has to be respected when we are planning.
And of course, with modern radiation or radiotherapy techniques, we actually have the chance to spare the bones a bit better. Obviously, they're more important for non-limb situations like parameningeal sites for RMS, where we've got a very complex tumor volume, not such a complex tumor volume for the extremities, but you are able to spare the bone. However, while with conventional radiotherapy, you're only treating maybe a section of the limb, but with conformal, you're only shooting limbs right through. So, does that, do you think, have a risk of secondary malignancies?
Yeah, obviously, as seen here with IMRT and the newer techniques, obviously the chances of complications are much less. And not only that, I'll just add that previously the edema was post-op edema due to radiation was also high, which is now less with the newer techniques. Regarding the secondary malignancy, yes, we have seen secondary malignancies like angiosarcomas, which has happened because of radiation. Though not very common, but yes, there's literature there.
Yeah, so the most common radiation-induced sarcomas are MFH and angiosarcoma. And the primaries, of course, were not necessarily sarcomas to begin with. So, common situation is breast cancer, where we obviously give radiotherapy routinely. And you can get sarcomas in those situations. And in these cases, if it is advanced, then these have a worse disease-free interval. But not necessarily if it's a small lesion. And just a few points on the modern techniques. So we've talked about IMRT and BMAT. We have some evidence that if we do image-guided radiotherapy, that is, if we verify that we're treating what we want to treat, that we actually achieve a better toxicity profile. There is data on this. There are situations where we will have to use definitive radiotherapy, and this was a pretty hopeless scenario in the past. But now we have all these very exciting things, the particle therapies. So we have a proton therapy center already, and the second one coming up very shortly. And we just want to finish off maybe with a quick word on these. Because I can see that you have a question. Yeah.
I don't have a question, I just have a comment. Your previous slide about radiation-induced second malignancies and sarcomas. It's my misfortune, or I'm fortunate to see two of these. One is already published 15 years back, radiation-induced angiosarcoma, which has already been published as a case report. And now I see another patient. She was radiated with chest wall for breast cancer 15 years earlier, and now she has come back with a chest angiosarcoma of the chest wall, the same chest wall. So this is just a personal experience. Radiation-induced angiosarcoma. Just to make it.
Yeah, it is definitely a real outcome, although it's thankfully rare. So the particle therapies, do you want to just tell our surgical colleagues what we can offer?
So obviously, it is now perhaps the treatment of choice whenever it is available and in those scenarios where it is indicated, because obviously we can give much more higher dose compared to the conventional treatment, and the sparing of the normal structures obviously to a higher degree. Especially in pediatric cases where we are very skeptical, I think there we should definitely consider whenever we have the opportunity of particle therapy.
So yeah, because they can actually deliver a higher energy, they're less influenced by hypoxia, which is sometimes an issue. And because some of them have something called a Bragg peak, we're actually able to confine the dose without an entry or an exit dose. But having said that, in the real world, it is still beyond the reach of 99% of patients, and we have to enable them to access it in a more meaningful way. So I think I've pretty much run through all my questions. So, if any of you would have a comment.
May I ask two questions to the radiation oncology colleagues? So number one is that, especially in pediatrics, we often face this problem when neoadjuvant RT has been given. Typically, a dose of around 50 to 50 protein has already been given, and now after the surgery, it is an incomplete surgery. So how much is the boost? Should it be 10 grade, 20 grade? Because we are always concerned about the cumulative dose in children. So that's question number one. And second question is there any evidence of fractionation technique, like in standard fractionation versus hyperfractionation? Is there any benefit with hyperfractionation, either in neoadjuvant or adjuvant RT?
Right. So just to take up those myself, and I will ask the people in the audience as well. So I think for pediatrics, the issue was about compliance. So obviously the regimes were quite brief, and some of them were hypofractionated, although not for RMS, but in the past when we used to treat retinoblastomas, that was a hypofractionated regime. So I don't think hyperfractionation has been explored, because it would be very difficult logistically. And as far as a post-op boost is concerned, I think the Canadian group had worked with it, Brian O'Sullivan's group, and they said that there wasn't any benefit. So that's a situation where we got significant residual disease after pre-op treatment. That would be a situation where probably further radiotherapy wouldn't help. Would any of the other RADONCs in the audience like to take this up? Propindu and Kazi, if you can take it up.
For brachytherapy, I think we do hypofractionation because we generally give BID treatment around 5 to 6 grades per fraction. So we can end up the treatment within 1 week, where for external beam radiotherapy it takes around 6 weeks, which is, I think, beneficial for pediatric or any patients as such. For other patients, I think during IMRT or anything, I think hypofractionation or hyperfractionation is still not practiced. Generally, we practice 1.8 to 2 grade per fraction.
Yeah, for pediatric brachytherapy in sarcoma in pediatric patients at PMH has long series of their experiences. It's absolutely without any significant toxicities. The main challenges of giving BRT to the pediatric patient is to keep the patient lying and machine. This is very challenging. And every setup doesn't have any boil separators or daily anesthesia setup, so this is quite challenging. So brachy should be beneficial for those patients.
Yeah, that's a good take-home point that brachy has some very practical implications in terms of time frame and logistics. So we are at the end of the panel discussion. Thank you to all the panelists for bearing with me.